So good afternoon, everyone. We're here to talk about Imperial's journey in engaging budget holders, services and clinicians in service line reporting and PLICs. Just to start with, I'll be setting the scene, and then I'll hand over to the experts here to really go through the detail of what we did. Let's just start with introductions. So I'm Hina Khalid. I'm the Finance Business Partner for Business Intelligence, Productivity and Planning. I look after the profitability and costing team and lead on trust-wide efficiencies and transformation opportunities from a financial perspective. I have with me, sorry, I need to not move my head. I have with me here Selina St. Hill, who's a finance manager for costing. So she's a trust lead for patient level costing. I will be talking a little later on. I also have Helen Lane here with me, who's the lead for the ISLR, producing the monthly ISLR information, and she will also be talking a little later on. We also have another member of our team, Harmeet Bains, who's not here with us today, but he supports the rest of the profitability and costing team. So just some fact and figures about Imperial. We are a large treating trust. We provide acute and specialist services to approximately 1 million patients annually. We are based across 5 sites, mainly based in, totally based in North West London. And we have 2 emergency departments, as well as a major trauma centre at our St. Mary's site. Our turnover is approximately 1 billion. We employ over 10,000 staff. And in conjunction with Imperial College, we were one of the first in the UK to be accredited as an academic health science centre. And this was all supporting rapid translation of research and excellence in education. So in terms of the costing function was brought in-house around September 2012. 2 systems were implemented, so the Albatross ISLR system as well as the Prodacapo PLIC system. And around 2 years ago when I joined, the profitability and costing team had been really successful at delivering a lot of the external returns in very tight timescales. So the reference cost, the monitor PLIC return, as well as bespoke analysis for Project Diamond. During this time, there'd also been a new PAS system implemented, Cerner, and there'd been an organisational restructure. So a lot of our clinical business units were moved around, leading to a lot of, late nights understanding where the cost centres had now gone to and what they all mean. All in all, in this time, there'd been variable internal usage of the profitability and costing information. The profitability and costing team had published all of their information on ClickView. So at Imperial, a lot of our reporting is done via ClickView. So whether it's finance, workforce, quality or performance, all of that monthly reporting is published on ClickView, and all trust users will have access to it. And monthly ISLR information was also being published in the division plags, though it was the last slide, so probably not regularly discussed. We also tried to set up a profitability user group and had limited success. All in all, we weren't really using the profitability and costing information consistently to make decisions. So we all decided that this had to change, and we thought about what do we need to do to change this? The themes of what we focused on, the first was really we switched our focus onto an internal customer. And the internal customer wasn't just the clinicians or the service leads, it was also other corporate departments. So the wider finance department, information, the medical directorate. The rationale for this was there was no way that we were going to go out and meet all the services and clinicians to explain the data we had and how brilliant it was. We needed to really have other champions who had regular face time with a lot of the clinical services. Secondly, we committed to providing the data and information more reliably. So the monthly ISLR information was in the division of plaques. We kind of revamped it and made sure that we were in time for the monthly management accounting process. As well as the PLICS data, we committed to at least providing it twice a year, building up to quarterly. The other theme was we looked at how do we make this data more usable. A lot of our ClickView apps were designed for, not even just finance users, probably other costing users. So there was a lot of selections you could do, a lot of different data extractions. And to a non-finance user, it was really quite difficult to navigate, especially if you didn't understand the data set and all the different connections that needed to be made. So we really revamped our ClickView apps, really simplified our offering on them. And although not all the data was available all of the time, it was easy enough to use, and then people could ask for some more bespoke data extractions for any analysis that they wanted to do. Lastly, we looked at improving the accuracy of the data, and the way we tackled this was there was no way we were going to check all the different data sets and make sure they were accurate all of the time. We really encouraged, and we had a really good Deputy Director of Finance who really supported this in getting other departments to really take ownership of the data that they were providing us. Whether it was information or clinical support services or service leads, we really encouraged everyone to really take ownership of the data, build relationships, and this really helped us preempt any changes that were going to be made. So we weren't reacting to certain data sets suddenly being changed and having to figure out what happened. So we had a plan to change a lot of the stuff incrementally in 6-month chunks. However, then we were faced with some emergent requirements that really increased the pace of change considerably. We kind of had to juggle a lot of things all at once. So firstly, there was the unidentified SIP challenge, which I'm sure a lot of you face, and the trust decided to do service line reviews across the trust for every single service in the trust. Selena will talk a bit more about this, so I don't want to steal her thunder, but the whole premise was, where are the unidentified efficiencies that we haven't seen? So the finance information that was used for that was the profitability and PLIX data. So that was, suddenly hit us and we had to react really quickly. Then the second part was, there was a director of strategy who was leading a lot of portfolio reviews. So really looking at each of the divisions and figuring out what are the services that we want to grow, what are the services that we want to rationalize. And again, the profitability and costing data was key to that. So I'm just going to hand over to Selena, who will talk through the benchmarking reports.
So the premise surrounding this slide is, how do we produce a report that non-finance, non-accountants can use without an accountant, a costing person being in the room to explain it to them? And hopefully as I go through my slides, that will become clearer to you as to what we're trying to get to. So I just come back from holiday. Still had that post-holiday glow. And I get an email from my deputy director, and the rest of these lot, they're still on holiday, it's only me. So I thought, better open this thing, because I'm the only one around. And then I read it, and it mentions about the reports that Hina talked about, the service line reviews. We've got the chief operating officer, the medical director, they're meeting with the chiefs of service without any finance people to go through their service lines. And they want data from our team to support this. They want consultant profitability, HRG, procedure profitability, as well as some benchmarking data. It was the 7th of April, and they wanted the first report on the 16th of April. Post-holiday glow was gone. So my Deputy Director of Finance, she's a very clued up person, and she was a wonderful support to us. She's very familiar with all the ClickView apps that we have in the Trust, including our own ClickView apps. So she saw the opportunity where we could use the information in the organisation. And as an accountant, I did do a cost-benefit analysis. As Hina talked about the emergent stuff that came, the cost was going to be high. It's going to take a lot of time and work from us. But the benefit was even higher. It was something that we were really keen to do. So what is it that we did do? Now, as I said, there weren't going to be any accountants, any costing people in these reviews, so we wanted something that would grab people quickly, something that they could understand quickly without us having to be there to explain it. There were 3 core elements that we wanted to incorporate into the reports. We wanted to use our PLIX data. So we wanted to use the activity, the income, and the total cost. And we wanted to use the benchmarking data. We wanted to have that against what our costs were. So we chose to use the London Shelford group. So that consists of Guy's, King's, and UCLH. And that's where we have that last column there. That was the peer average cost. And then we also wanted to incorporate non-clinical data, because obviously it can't be everything with a pound sign in front of it. The consultants have to be able to relate to other things in that report. So those were the core things that we wanted to incorporate. And Helen and Hina, they did a lot of work in terms of the narrative. So we wanted the report to be balanced. We didn't want it to be like an exception report where we were just focusing on the negative stuff. Even though you might have noticed we've got that orange rectangle around there showing the negative stuff, but obviously that wasn't supposed to be the focus. So that's the main thing that they had at the beginning of the report. You had your overline service line review by pod, so you can see where the headline issues were. And then after that, and it's not on this screen, we showed the top 10 least profitable patients. And that was just to give them a view, really, of the problem patients that they had, so to speak. And in some cases, that loss that those patients generated was, quite a higher percentage than we expected. So then that would lead to conversations like, are you having problems with delayed discharges, or are there a lack of rehab beds? And then the other thing that we had incorporated in the reports were these S charts. Now, the reports were done by point of delivery, so you can look and see within each point of delivery how you were doing. So the S curves, which are the two charts there, those are the charts that we like to use because I think they're quite stark in what they show us. So on the x-axis, we have the number of patients for that point of delivery, and this is one service that we're looking at. So you can see the contrast between the day case in terms of the profitability on the y-axis and the non-elective that's here closer to me. Now, we use these S-curves when we were talking to our plastics service, and it was quite stark for them when we showed them this. Before in the trust, I would say that income was king, and people would just talk about the income that they were making. So they would say, oh, plastics said, oh, we're making X amount of income. But then we were able to show them their profitability reports, and they're like, oh. And so their chart actually looked like this. They were making losses in non-elective. And then, can you believe what they told us? They were actually turning away all the simple day case work that was actually making profits for them. And they were concentrating on the more complex, interesting work, the non-elective and elective. So that really changed their thinking, and they started to think about capacity. Could they have more work in day case? What can they do? So as I said, we wanted the report to be balanced. We just didn't want to look at the negative things. We didn't want to talk accountancy speak in the language that they can understand. So although it says here the 15 least profitable HRGs, we did look at the 15 most profitable HRGs. So we looked at HRGs because we thought those are the things we do routinely. And if you're going to say there's something wrong with the bad ones, that means you're going to have to reject the profitable ones. And so we thought that brought it in balance, really, by seeing those perspectives from both sides. So on this chart, we have the least profitable, and the work that Hina and Helen did. You can see we've highlighted planned procedures not carried out, and we thought that that was a recurring theme for a lot of the services that we looked at, and again, with non-elective being an issue. So as you can see there, we've got the activity, the total cost and the income, the surplus and deficit in total, the unit, and the Imperial average cost, and the benchmarking data that we pull from the app. We didn't use consultant profitability. When we thought about it and we discussed it, we didn't really want to lose the battle before the war even started, so we just thought we show them the headline figures. They're not accustomed to seeing this data before. It's going to bring a lot of discussion, and I would say that that was a good choice that we made. It's funny because a lot of you guys, when we come here, we hear you talking about data quality and how people are going to rubbish the data. Hand on heart, no one ever said to us, oh, the data's wrong, the data's rubbish. You know, they just accept it. They don't even ask where you got it from. There's a benchmarking group. I've been chasing getting their consumables data to get into our costings that I can't get. And they just ask me for the benchmarking data, and I'm like, don't you want to know where I got this from? No, they don't. We've not had any of that. I mean, Sam over there that used to work with us, he made good his escape. Yeah, we've got a vacancy for an AA. We used to have more kittens about the data accuracy than anyone else. So there was this one day we were in a dive for surgery, and it was a planned dive. So anytime I go into any of these meetings, I look at who I'm going to go through. So I'd done my plan of which patients I was going to look at. And my business partner, she just says, well, let's look at that patient. And she can't really see on my face that, I didn't look at that patient before, let's not do it. But anyhow, we look at the patient. And that patient has been in critical care for 25 days, and I've got no critical care income. So my first thought is, home. It's not work in progress. We build critical care by the day. So, second thought, panic stations. Oh my God, my data's wrong. Why haven't I matched any income with this expenditure? But then if I haven't, then my whole methodology and the model's wrong. How come I've never noticed this before? So then my third thought is just stay calm. Don't let her see the inner turmoil on my face. You know, it doesn't quite look right. We'll get back to you. I'll go and see what's going on. Manage to get through the meeting. So then I rush out the meeting and we go into the ICAS system to look at this patient. Oh my God, they really were in critical care for 25 days. So yeah, I've costed them up right. But where's the income? Go look in my income feeder, there is no income. When it boils down to it, that patient was under a locally negotiated tariff, which included critical care in that tariff, and it was only about 2 days of critical care. We had 25, so that's why that patient was making a stonking loss. And they were able to analyze the length of stay data for that tariff, and they saw that we weren't very clever in the way we negotiated that tariff. This is the non-clinical data that I wanted to bring in also to complete the package in terms of what we've provided to the services. And I must say this does bring back fond memories. I'm not the main operator of the system. The main operator of our Plix software benchmarking was still in Sri Lanka sunning himself, and I'm not familiar with the stick. I talked to Mike about getting the data off the stick, realized it's a WinZip file, and so what do you have to do at my trust to unzip a file? You have to call IT to get WinZip, you know, and then they give you the wrong WinZip, and you're like, what am I doing? So eventually I get the data out because certain people are over my back about, just put screenshots. I'm like, you crazy? You know how much work that is? I'm not doing that. So this definitely brings back fond memories. I think you should recognize it, but though I do think my colors are a little nicer. Hint, hint, Dimitri.
Okay. Now our data's been used for something trust-wide, how do we embed it? How do we make sure it gets looked at continually and understood and used and improved? Training. We decided that training was the answer. Up until now, training had been a little bit ad hoc, so how could we structure it to make it more consistent? Make it classroom-based. Plix, ISLR, benchmarking, service line reporting. None of these are linear. It's hard to describe everything they contain in a guide or e-learning or, heaven forbid, a video. So, classroom it is, with one person presenting and 3 helpers to keep everyone on track with the ClickView navigation. Next, find a training room with computers, which all face a screen with a focused projector. Wow, feat in its own right at our trust. That done, what to include? There are so many integral finance parts to understanding profitability or service line reports. There's the general ledger, payroll, income, recharges, allocations, overheads, benchmarking. We can't do it all. And how long should the training be anyway? I'm a finance person. I could talk about service line reporting for hours. But perhaps an operational manager or a clinician has something else to do. Face-to-face time during business hours is quite precious, and they probably can't spend it all with us. And actually, who should we be inviting anyway? Just clinicians and managers? What about other budget holders? What about our finance colleagues as well? Decisions. Right, so we're in a training room. What else? Writing. For most, that's a distraction they can well do without when they're trying to learn as well. So, no writing. I'm not allowed to take away their phones, but not needing to take notes as well is at least one less thing for them to divide their time between. So if we're not writing, how do we get a permanent reminder for our trainees? We can provide them with printouts and reference documents instead. But you know how that works. Everyone jumps ahead in the training. They end up in a different place to you, they're looking at the wrong screen, they've clicked on the wrong thing, they're not listening to what you're saying, and generally everybody just gets very confused. Also, everyone takes away the printouts, even if their intention is to put it on the shelf and leave it to gather dust. And we are, after all, supposed to be a finance department who's promoting waste reduction. So, we email them everything after the training session. The slides, the detailed screenshot walkthroughs, question and answer sheets for practice, the whole lot. What we do is to run 3 lots of 2-hour sessions, 2 days a month. 3 of us combine to present ISLR and PLIX, our service line reporting generating mechanisms. We've standardised the content and to a certain extent the delivery, so we can cover for each other. Ultimately, several members of the wider finance team should be able to present this, and yet we'll know that the big agenda items will still be discussed. We decided not to restrict access, so budget holders, ward managers, clinicians, GMs, service managers, lab staff, finance colleagues, even information and contracting teams. Anyone who might find it useful to know this information is available, anyone who helped us generate it, anyone who wants to help us in sharing the message with a wider audience, and anyone who needs to worry about the scissors of doom in their service. This is the latest term at our trust for the unfortunate circumstance where income is going down but costs are going up. They probably need to come, everybody else is welcome. As you can imagine, that leaves us with quite a broad underlying starting level of knowledge. So we ask a couple of questions just to try and gauge what sort of audience we've got. Our first target group of trainees was in fact our business analysts and business partners. Why? Because we need them. We need a united finance face. We need to communicate with our budget holders in the same way. And that means our business partnering team need to understand what we're doing. We also realised that finance has a lot of contacts already out in the departments, out in the services. We can't get to every budget holder out there, but with business partnering on board, we have a much broader reach. We can't possibly be on hand to answer every question as it arises. Business partnering can't either, but between us, we have a better chance. And they helped us drum up business for our training sessions. We try to make every training session as interactive as possible. And this is my favourite slide. We try to get the participants to tell us whether the resource should form part of that particular patient episode. It's a pretty simplified version, but it does at least get them talking. In fact, one person actually asked us if we did this manually with our rulers and highlighters. The other nice thing about this slide is that, as you can see, upon discharge on the right-hand side here, the patient is smiley, cheerful, with colour back in their cheeks, an indicator of Imperial's first-class care. It must be true, it's on the slide. All our slides are 100% accurate, even the one that says elderly medicine makes a profit. So, how's it gone? Pretty well overall. The more we do these sessions, the more we realise this is often the first time anyone has seen this data all pulled together and linked. It's shown them things that they have not seen before and didn't even know were available. It's getting them talking about how they might use the information to get more informed decisions about patient care. And some exciting projects are coming out of it. Just before we run through some of those projects, I thought it might be nice to share with you a few hints and tips, the kind of do as we say, not as we do part of our learning curve. It's not always plain sailing. There have been a few hiccups along the way. So these are some of the little things we've learned. If your points of delivery look like ours, and you're running through what they mean, DC, day case, EL, elective, OPFA, outpatient first attender, try to remember to put the OP on the front of OPFU, not just use the last 2 letters.
At least they were listening, Helen.
It does make the room sit up and listen, but maybe detract slightly from the message you're actually trying to get across. 3 months into our training, we finally discovered how to issue the feedback forms from the online booking system we'd been using. We clearly needed a little bit of training of our own there. Happily, this did actually generate some responses, most of which were very positive. But through the feedback we received, we discovered that you can't please everyone. These actually came from exactly the same session. Well-paced and too fast at the same time is pretty good going, even for our team. But what it does show is that whatever we do will only ever be right for some people. And whilst our standard offering gives a good basis, we do need to remember those who need some more support. So we need to think about a more versatile package, maybe with some refresher sessions or additional sessions, clinics, focus areas, peer support, those sorts of things. Other ways of bringing everyone along with us. And finally, once we'd run out of people we knew to invite to training, and once the rest of the finance department had run out of people they knew to invite to the training, and once Selina had stalked everybody she possibly could in the lift, once all those people had run out, we decided to put up a poster to generate some more bookings and cover a broader range of staff. One of the team designed the poster, included all the relevant information, tweaked it, improved it, even made it look vaguely interesting. But I can't show it to you. Up it went on Wednesday evening. By Thursday morning, it had been taken down with a wrap on the knuckles, the wrong shade of blue or something. So make sure you get your internal comms on board.
Thank you, Helen. So I'm just here to talk about what we're doing now. The emergent work we did, I think, increased the profile of the profitability and costing team considerably and beyond our expectations. This has meant that we're involved in a lot more work programs across the trust. Just to give you a flavour of some of the stuff that we're involved in. So firstly, we've got the Clinical Strategy Implementation Programme. This is all about implementing the recommendations from the service line reviews that Selina spoke about. So she mentioned one of the services about rebalancing their workload. There were some quick wins that were implemented very quickly, but there's also some longer term work with pathway redesign between sites and patient flow, which is the bottom chart on your left. And this is all about really mapping through all the patient resources and activities across the trust and really trying to understand where the bottlenecks in patient flow are. Normally there would have been multiple information requests to the information team, but because they realised that the PLIX data collects a lot of this information, they're able to just come to us and get a lot of this information and analysis. Secondly, we've continued with a lot of our ISLAM PLIX training, and the rest of the finance department is now following suit. We've also automated the service line reviews that Selina spoke through on our ClickView app. So there's a static part of a ClickView app where you can pick your service, pick however many peers you want to select, and it will generate a report that you can print and email to yourself. We've also partnered up with the Quality Improvement Team, and the Quality Improvement Team is a team within the Medical Directorate, and it's all about training clinical staff to make local changes quickly to improve patient care and experience. And where we've come in is we've helped them train the clinical fellows in profitability costing information and also help them with bespoke quality projects. A recent project is the Plural project, which is the picture in the middle with the woman with the needle. And this project is all about a procedure that's you use an ultrasound. It's an ultrasound-guided procedure where you inject a needle to drain liquid from the lung. And we're working with a really fantastic consultant whose hypothesis was that if we followed the best practice guidelines, we could really improve patient outcomes, patient care, reduce length of stay, and from a financial perspective, reduce costs. So win-win across the board. We drilled down into the PLIX data and actually were able to provide evidence that that was the case, and now we're really helping her set up the service across the trust. We're also looking part of the sustainability reviews. So this is as part of the 16-17 objectives across the trust. All services have to come up with their own local sustainability and transformation plans. And the poverty information is really key to that, and they're all going to be clinically led. So we're continuing to really focus on trust-wide projects. So thank you very much for listening, and we're happy to field any questions.